All right, so I'm just gonna start now, and then people are still trickling in, but it's okay. Um, Thanks for coming, everyone. So this is going to be the Clinical Specialties Workshop that ACCP is having in collaboration with APA. The topic we're going to discuss this time is going to be on telemedicine, and we have Dr. Badowski and Dr. Chan joining us today. Next. Just some really quick record keeping at the beginning. If you haven't done so already, please click on the link in the chat so you can get your attendance for today. In terms of ACCP announcements, there's going to be an ACCP annual meeting. If you haven't signed up for that yet, you still can. I believe if you're a student, right now it's about a little over $100. It's going to be all virtual. If you have any questions, just let us know. We also have a deadline to join the PRN committee. So if you're interested in anything like that, catching up with clinical pharmacists and presenting advances in the field, then you can definitely apply with us. The deadline is going to be on October 20th, Tuesday. We also have a journal club happening on Thursday, October 22nd as well. And a GBM for ACCP happening on Tuesday, October 27th, going over the Clinical Research Challenge, which is a team-based challenge where you go over primary literature and you develop your own research project for the competition itself. If you want more information, just head on over to the GBM, we'll let you know. Next is going to be the APA announcements.
Hi everyone, in terms of the APA announcements, we have our second GBM. It's going to be an alumni residency panel. We're going to be inviting our previous presidents, Dr. Hannah Kim and Dr. Tiffany Wu, and they're going to speak about their residency experiences, and all are welcome to join. This is going to take place on Zoom during lunch on Tuesday, October 20th.
All right, and I'm just going to introduce the professors real quick. So first one we have is Dr. Melissa Badowski. She's currently a clinical associate professor in infectious diseases pharmacotherapy at UIC. She also works as a pharmacist for the Illinois Department of Corrections telemedicine services, providing HIV consults to the prisoners. She also serves as members of a couple boards. So we listed a couple here: pharmacotherapy specialist council member to the Board of Pharmacy and Specialty, a review committee member of National Association of Boards of Pharmacy, and she also founded the ACCP HIV PRN, which we discussed a little earlier. In terms of education, Dr. Badowski got her PharmD at Midwestern Downers Grove here in Illinois. She did her PGY1 and PGY2 at the University of Maryland Medical Center in Baltimore, Maryland.
Hi everyone, I'm Kylie, I'm P3. So I'm just gonna go over Dr. Chan's current position. So Dr. Chan, she's a clinical pharmacist at gastroenterology and hepatology. She's also a clinical associate professor at UIC College of Pharmacy and College of Medicine under the section of digestive disease, nutrition, and hepatology. So during the past decade, Dr. Chan has many opportunities to serve in several clinical capacities. She became an assistant director of the clinical pharmacy in the ambulatory care at University of Illinois Health Medical Center in 2007. She also established a hepatitis C telemedicine program with the Illinois Department of Correct Hepatology Telemedicine in 2010. So her clinical skills of expertise in creating the hepatitis C service revolutionized the specialty pharmacy service at UIMC. And under her direction, rheumatology, neurology, and gastroenterology specialty pharmacist services were created, which mirrored a model of the hepatology service she had established.
In regards to her education and training, she got her PharmD at the Massachusetts College of Pharmacy. She did her PGY1 and 2 at the University of Michigan. And as Kylie said, these are some of her achievements.
Yeah, and before we go to the questions, if Dr. Badowski or Dr. Chan, you wanted to say something about yourself or your training or anything else?
No, you all did a wonderful introduction. Thank you very much.
Ditto.
Sounds good. All right, so we're going to go into the questions, and feel free to discuss openly or follow the guidelines if you like. But the first question we have is, if you remember, which rotations during your last year of school were the most influential in your decision to pursue a residency or fellowship, and ultimately your current practice area?
I have to laugh that you said if we remember. Makes it sound like it was that long ago. So with that being said, I guess I'll take the reins first here, if you don't mind, Dr. Chan. So for me, I definitely do remember my most influential rotation because it really changed the trajectory for me of where I wanted to go. I don't know, some of you know this about me, but I never wanted to teach and I was going to be in retail. So clearly I'm very off that track. So it was one of my P4 rotations. It was November, so maybe right about now. And I was taking an infectious diseases rotation from Midwestern. And I took ID because I was very intimidated by it. I didn't like it. I didn't know much about it. And it was at Christ Hospital. So many of you heard of Dr. Joe Lovato. He's the person who really changed why I'm here today. And so he debunked the myths of infectious diseases. And I became really interested. And that's really the role for me that made me want to pursue a residency in this area. I did like a lot of everything, so it was really hard for me just to commit to one area. And for me, my general residency was PGY1 in pharmacy practice. So I'm historically trained as an inpatient pharmacist, sprinkled with a little AmCare, and now I'm mostly AmCare. But then my second year was in pharmacotherapy, so I still got a pretty broad array of experiences, but I really started to focus in on the ID and HIV side of things. And so if it wasn't for that rotation that I took as a P4, and because I thought it was hard, I wouldn't be in front of you today doing what I do.
Excellent. So for me, it's interesting because I can't even speak. It's been so long ago, and I won't date myself. But let's start with high school. For those who know me, I almost dropped out of high school, so you and I wouldn't even be talking here today, all due to swimming class, because I still to date still do not know how to swim. So I missed the entire year of swimming. I was going to drop out of school, work in my parents' restaurant, and that would have been it for me, and I would still be in Massachusetts. But I guess the moral of this story is keep your friends really close, because they're the ones who kind of get you through tough times. And if it wasn't for one of my dear friends who said, stay after school, we'll get through the 3 weeks to make up your swim lessons, I wouldn't be where I am today. So then I ended up in pharmacy school. For some strange reason, we only had like one school in Massachusetts. I applied, I got in, and residencies and fellowships, I didn't even know what they were at that time. And knowing my history, I just kind of followed the lead. So that's what I kind of did. In my class of 300 who graduated with their BS in pharmacy, there were only 17 of us who did go on to get their PharmD degree. It was supposed to be 16 students in the class, but the valedictorian that year decided to drop out, and I was on the wait list. So again, fate or luck or whatnot got me into that final spot. But then the valedictorian last minute decides to come back, and the reason for the odd number. So I kind of cruised through my 2 years of PharmD school, still didn't know what I wanted to do or know what a residency was at that time, but my close friends were gonna do a residency, and I just thought, I guess I'm supposed to do one as well. In terms of areas of practice, who knew? Because I just thought it was always retail, like all UP1s or pre-run students coming in thinking, well, pharmacy is just retail or hospital, but didn't know there's so many opportunities out there until you go through the schooling. And then I chose a residency, and it's different back then than now because I only put 2 to match, and luckily I got into one of them, and it was University of Michigan. So still, as of that time, I still didn't know what I wanted to do, but it was my mentor, Rosemary Berardi, who was the god of GI, is the one who influenced me to where I am today. And I call her as my mom as of today still. So I think for my journey, let luck be. Something that Kaylee mentioned that was part of my past is being the Assistant Director of Clinical Pharmacy Services at UIC. I've never imagined myself being in management, and somehow I ended up there. So if you're not sure what you want to do, it's okay. It's still early. A lot of people will keep asking you over the next couple of years until you graduate, and even thereafter, what do you want to do in the next 5 years? It is totally fine to say, I do not know. But there will be one magic person in your life, which we always talk about networking, that you'll hear throughout your school year, as well as when you get out in the real world, that will change your life and make you who you are today. So I guess that's where I am right now. I don't know, any questions? I'm not going to follow the script that Kaylee gave me. As you guys know from APA, I can't speak for ACCP, but those who do know me, I'm just going to ramble on. All right, I'm going to shut up now.
That's okay. I definitely appreciate any additional feedback you have. This is just a guide, but thank you. I'm gonna go with the next question. So what do you think gave you the biggest leg up to get the position you are in today?
For me, I'll just say luck. I never imagined myself going in and taking care of prisoners for the state of Illinois, never mind trying to figure out how to turn a Polycom machine on. Anyone who knows me, I'm computer illiterate. So it's just sheer luck. I just kind of go with the flow of things, and a position opens, give it a try. Don't be afraid. Even though I say that, I still don't know how to swim as of today. And we do have a pool upstairs. But I would just say, if there's an opportunity that passes your way, consider it, but don't think you have to do it. But don't be afraid to jump in the water and swim, because you might actually survive. You don't know. And then at least you have the experience under your belt. So
I think for me, it was really taking chances. Sometimes it's okay to take a chance. And I think about it from the beginning of my residency until where I am today. I took a chance and I moved out to Maryland to follow a boy. That boy became my husband and is the father to my child now. And my family thought I was crazy. I'm an only child, and how dare you leave the family? I think it's okay to take a chance in those regards. And if I hadn't gone to Maryland, I would not have found the world of HIV. It's kind of a different world. I always like to say that the patients found me. I started to learn about them. I got to see that I could be as professional or as unprofessional as a patient wanted me to be. Sometimes I have to swear to get through to them. It's whatever it takes. And then the safe thing was staying at Maryland to take a faculty position. Again, that was the only thing that was available. It wouldn't have been my first choice. But when I was looking for jobs, faculty jobs were available. And so if it wasn't for that, I probably wouldn't be getting to know all of you as well as I have gotten to know you. And then I think about just perusing the job boards to see how could I come back to Illinois eventually. And in 2010, I saw this advertisement for telemedicine. I was like, what the heck is this? And when I interviewed, nobody could really tell me what it was or what it entailed. But it was the unknown. And I think it's really the unknown that gets you excited. What excites you about the future? And so, yes, we could do the same thing day in and day out, but it's really about taking chances sometimes. And sometimes the chances are going to, work out in your favor, and sometimes it's not. But you won't know, and you'll always second guess, should I have taken that opportunity or not? And so for me, I knew I wanted to come back to Illinois. I still to this day miss Maryland. I have some of my greatest friends and social network that's out there, but it's only a plane ride away. Right now, it's a little bit more complicated than that given these times. But I think it's really about just kind of going into the unknown and a lot of the uncertainty. It's okay. Like Dr. Chan said, sometimes you don't really know if this is the right thing that you should be doing or not, but give it a try. And at least if you give it a try, you know that you've done your best. Like that would be like me going and giving cardiology a try. I know I really don't like it. I did a rotation in it, still don't like it, but at least I gave it a try. So I think those would be, it's okay to kind of just go into the unknown. And then, you know, you can say, at least I tried it, and no, I'm not interested in doing this again.
Dr. Chan, did you want to add anything?
No, I mean, I echo what Dr. Badowski is saying for sure. I think that all of you who are doing this day to day right now, going to school, you're like, God, this is boring. I'm sitting behind a computer screen, but it's an unknown. How did we know 9 months ago this is what we're going to be doing for quite some time, unfortunately? And I think you just have to kind of take it at strides. Take it day by day. And, you know, for many of you who will be going in your 4th year or your P3 year, rotations is going to help you kind of decide what you want to do in the future. If there's a topic that you're kind of afraid of and you're not quite sure, take a stab at it. You know, cardiology, like Dr. Badowski said, is like the worst organ that I can ever think about. It's like, I hate the heart. I know it pumps something. I know there's, you know, in and an out, and that's it. But God forbid, if I lost my job here at UIC and I'm going through and I need a job to put food on the table for my kid or, you know, my family, I'm going to do what it takes. So if there's any lesson, and you guys heard me say this over and over for APA and those who do know me, the one class that should be close to your heart is going to be drug information. I think that for me, I went through my entire residency and my 2nd year residency specializing in GI disorders, not really doing that much in liver. And I didn't know what position I'm going to go into upon graduating. I still didn't even have a job when I was graduating my residencies, because no one knew about liver diseases. Hep C wasn't a big thing back in, you know, the late 90s. There was only like one drug for like almost 15 years. So who knew that that's what I would end up specializing in? And the position that I was hired for here at UIC was in liver diseases, but all I knew was stress ulcer prophylaxis. So I was going to do I did a 1-year GI residency, and the closest thing I was going to go into was critical care. But luckily enough, Dr. Lau at UIC had contacted me, and I've been here since. So I would just say, again, networking and just keep your options open. Worst case scenario, I come to UIC, I try the liver position, I use my drug information skills, and I'm where I am right now. If I failed, I failed. That's all I can say, but at least I tried it. No different with other positions that I've had, and no different for you guys. If you've had me on rotation, what's my first thing I tell you? And those who work with me in the IDOT clinic, make as many mistakes as you can right now. You're not going to kill anyone. The ones who has to be responsible is Dr. Badowski and I. So if they die, it's on our time. But when you guys are out in the real world, you have no one else to fault except yourself. So make more mistakes now. The more you make, the more you remember not to do in the future.
Okay, thank you. Next question is, what does your typical workday or week look like?
I'll let Dr. B go with that one.
It varies. There's times in my life that I still feel like I'm a resident, where I'm up till 2, 3 o'clock in the morning, even later than that, to get a deadline completed. And I think, you know, there's some times where there's a ton of flexibility. So in the summer, I really take advantage of summer kind of break. And we don't go on break, but we're still taking care of patients and everything along those lines. But a lot of the teaching is reduced significantly. So it gives us a little bit more flexibility. Right now, we're in the heart of what would have been conference season, is what I call it, in October. So I think like every meeting that or organization that I belong to has a meeting during this time. So it ramps up efforts for research and presentations that we're giving and posters that we'll be presenting. But then there's some weeks that it is just definitely, you know, my 40-hour work week. But all 40 hours doesn't have to be from 9 to 5 or 8 to 4 or along those lines. So I definitely think it's based off of what you're involved in, how well you learn to say no, or, you know, yes, you get to be a little choosier in your career as you become more seasoned. That's what I keep trying to learn. But I also think that it's a really good, at least for me right now, work-life balance. And I don't think that was really evident until I had my child. And again, I know some of you may have a significant other, some of you may be, you know, thinking about having kids in the future. This, I think, you know, where I was when I first came here, it was all work, work hard, play hard. I think that was like my mantra, and I still kind of live by that example. But a lot of things were put into perspective when I had my son, and I realized that, you know, there will always be a manuscript, there will always be research that I need to devote my attention to, but you only have so much time with your family and friends. And I think it took me a little bit of time to realize that. At the end of my life, am I going to be thinking about that paper I published or the time that I spent with my family and friends? So I think there's, you know, something to be said about that. I think about being in a retail setting where you have to be there for a certain period of time. During my time at UIC, some of you know my dad got really sick, and I had to focus a little bit more time and attention to being with him. And one of the things from the community here was take care of your family. That comes first. And just knowing that, you know, from my colleagues, from those that I also call my friends that are here, I think it's really important to understand that and to have that flexibility. If I were in the retail setting, I wouldn't have all that flexibility. So I think, you know, there's pros and cons to each job. But again, I think, you know, the support and the flexibility that I've had here, where yes, I am working till 2 or 3 o'clock in the morning sometimes. If I have to be in clinic, that is an absolute. And then the rest of the time I kind of can, you know, ebb and flow with what I do. When I'm teaching, that's another one of my priorities. So if I have a student on rotation, or if there's electives that I'm participating in, those are things that I have to be there for. But again, I think there is a lot of flexibility to what I'm able to do. I'll pass it over to Dr. Chan now.
Thanks, Dr. B. So I think with this question, I'm gonna not really talk about myself about this because everyone has a different work day, work week, and give you more of a global sense to what your future may hold in terms of what your typical day and week would look like. It really depends on the position that you're gonna go into. I can say, for example, during my administrative days, I had 25 clinicians who work in the ambulatory care setting. The vision and the mission, or the way that our bosses want the clinicians to work, at least in AmCare side, is 80% to be on service, seeing patients, and the other 20% would be devoted to research or teaching. And that is what the mission of University of Illinois at Chicago is. Some teaching, some service, and some research. So then if you decide to go into academics, the question is, what do you want to do? As I just stated, we have 25 clinicians. Some people actually do more research than others, such as Dr. Badowski and myself. So we may actually have more than just 20% or one day out of the week doing more research because we take that work home with us. Whereas others may choose, well, I would love to just do patient care. So they may want to just do all 4 days out of the week and see patients from 8 to 5. And other clinicians may say, I like to do teaching. And a perfect example for those who know her is Dr. Lori Wilkin. She has her own smoking cessation class and course. She does, rotation students. She takes many of them. She takes, residency residents on service. She teaches classes in the College of Medicine as well, I believe. So she may have more of teaching opportunities, and that might be a couple of days out of her week, and then a little bit less on research. So that's an academic situation. So if you're working at a top 10 school, you kind of decide what kind of week you want it to be. For myself and Dr. Badowski, because of COVID, we're dealing with prisoners, as you probably heard the news, we have had more outbreaks in prison. So at least for me in the liver worlds, my patient load has decreased significantly because of the outbreak. And they were saying that Hep C is not that important compared to COVID. So they are kind of putting those patients on the side until the pandemic is kind of eased down and we can see more patients. HIV is a different animal where they do have to be seen. So she's probably in clinic more than I. This week I have 2 days in clinic. Last week I only had 1 day in clinic. I probably won't have clinic the following week, and the week later I have 3 days in clinic. So every week is going to be different. And that's, again, more an academic institution. If you're working at a community hospital, you might have more clerkship students stop by. So your responsibilities there is going to be patient care most of the time, with some educating students on rotation, like a P3 student or P4 students or residents. And then you may not even have any research responsibilities because you're not associated with a college or a university, a college of pharmacy. And if you are, you might have a little bit involved. And then those who work retail, as you know, if you already experience it right now, it's typically a 8 or 12-hour day on your feet, and then you get the rest of the days off. But even in retail or in hospitals, they have a 7-day on and a 7-day off. You can work at midnights and you have your days free. So you kind of decide what you want to do in terms of what your work week looks like. It's not typical by any means. If you do a survey of all our clinicians here at UIC in the inpatient and outpatient, everyone is going to tell you something different. We can just tell you as a manager or a boss that there are certain objectives or expectations that you are supposed to meet. And then if you choose to go more than what is being expected, then by all means you can do that. And I think that's another discussion where we can have either now or another time, where if you look at our titles, well, Dr. Badowski and myself are clinical associate professors. And the reason why we have that title is because we do more research and we do more teachings than maybe our colleagues who are at a clinical assistant professor level. And then if, like Dr. Badowski, who does not really sleep throughout the week, she's going to get promoted in the upcoming years to be a clinical full professor. And that's because she's devoting more times and days and doing research, things that she loves to do. I'm getting old, as you know. I have a daughter right now who just turned 1, and I don't know if I'll still achieve that. People do know that I don't sleep in the middle of the night and I still do what I'm not supposed to be doing. So one day I'll get there, but I'm pretty sure Dr. Badowski will get there sooner. So everyone's going to be different. Your work week is based on what you really want to do. But no matter what, every job you go into, don't say that. You're going to get yourself into trouble. You'll say, oh, well, there's the door, don't come back. But you can definitely kind of do more, do what the expectations are. But then if you choose to do more, feel free. No one's going to say you can't do that. It's just to make you look good and feel good at the end of the day and know that you can accomplish a lot of things that you never thought you can do. So a lot of the organizational things are additional work stuff like ACCP, APA, for example, myself doing, you know, the faculty advisors and presenting at meetings. I don't have to do any of that, but I choose to. Working with my IDOT crew, helping them submit research to ASLD or ACCP that's going to be presented in the upcoming weeks. I didn't have to do that. They didn't have to do that, but they chose to do that. No different than all you guys being here, you know, Wednesday, or I'm sorry, today's Tuesday afternoon, it's 71 degrees outside. And why are you not outside playing or eating ice cream? Instead, you're here hanging out with Dr. Badowski and myself. So no different. Dr. B, anything to add?
Not at all.
Sounds good.
Okay.
All right. The next question is, looking back, is there anything you would do differently? And second question to that would be, what advice would you give current pharmacy students who are interested in telemedicine?
I'll let Dr. Chan start with this one.
Oh, I don't think I would do anything differently. I think that what I had been given the opportunity throughout my, I guess, 2 decades of life devoted to pharmacy, like I never knew I would end up here for this long. I thought, well, I'm going to do 5 years and I'm going to bail and go somewhere else. I think I would leave everything as is. I think that even with my admin days, it was a good couple of years of my life. It gave me an experience. So we always look back, but I think that if you didn't have those experiences, you wouldn't learn from them to help you determine what not to do in the future. So for me, I would just keep everything as is. And you know, for those who are interested in telemedicine, what's interesting, it's a buzzword right now. If it wasn't for COVID, we wouldn't even be talking about this. If it wasn't for, you know, specialty pharmacy services. I mean, I created our Hep C clinic back in 2002, and who knew a couple years ago that everyone wants to do specialty pharmacy services? I think it's just a buzzword right now. It's a lot to be discussed. You know, if you guys are the forefront, try to get our pharmacy services to be reimbursed. That's a hot topic, because still after so many decades later, we're still struggling to make pharmacists be recognized as providers to get reimbursed for our services. And we're still struggling to do that, primarily because our organizations, I'm not trying to name any of them, but there's only 3 major ones: ACCP, APHA, ASHP. We all don't want to play nice with each other. And if you know medicine or doctors and nurses, they're able to lobby and get everyone together at one time. When they find a cause, they move things very quickly. So for you guys, I think that if you can lobby and have everyone work together, that's where the goal is for all of you trying to get reimbursed for your pharmacy services. But if you're interested in telemedicine and the opportunities there, you guys are doing it now. I mean, if you have a phone and we're seeing each other on TV, there's no reason you're not doing telemedicine. I'm going to leave it to Dr. Badowski because she is the queen bee on this topic. She's going to give a talk at ACCP on this, and she's given many throughout the country. So she might have more in tune, more advice for you on that.
You're always so humble, Dr. Chan, but you do just as much. So looking back, if there's anything I would do differently, absolutely not. You know, I think about this, and a lot of my family, my friends, my husband will tell me there's not many people who love their job as much as you love it. And I really do. There are no 2 days that are the same. I think that just helps me because I would become really bored. But I also think that I enjoy coming to work every day, or some derivation of that, where half the day maybe I'm in clinic and then I go and I work from home the rest of the day just because of what's going on currently. But I will honestly say, for the last many years that I've been doing clinical pharmacy, I am really fulfilled in my capacity in getting to interact with students. I know when I first came here, there weren't many opportunities to interact with students. So I was given one recitation, which was in HIV. And I think I did that for 3 years. And I was like, that won't do. I need more. So that was where I started creating electives. And so I really enjoy the variety of the clinical services that I do. So aside from doing the telehealth clinic, I also do an infectious diseases clinic once every other week. So it still keeps me fresh on different ID topics. So I'm not just so specialized in one thing. And that's, I think, advice for all of you. Don't become so specialized in just a single thing, because at the end of the day, you will still have to know the drug interaction with transplant medications, even if you're doing ID. You will have to know there's drug interactions with hypertensive or heart failure medication. So although I try to avoid it, it still pops up. So I think that's one of the things that I would, tell you to make sure you expand. Don't just become super specialized in, one single thing. In terms of telehealth and what to do, as Dr. Chan said, you're doing this now. You are at the absolute perfect time that you're becoming comfortable interacting with each other. This is how, in a organizational perspective, I know a lot of people don't want to interact with people that are on the Rockford campus just because it's far away. I can't put two student groups together because they don't know each other. Well, now I think a lot of those barriers have come down, and this is how we've been working for many years on national committees and stuff like that. So I think this is the perfect time to get involved. Being able to connect with a patient via telehealth, I thought that I was really going to miss that face-to-face and one-on-one connectivity with our patients. I don't, because I get to see the service that we're providing. We're optimizing patient care. When we first took over telehealth with the Department of Corrections from the HIV side, we were only about 50% meeting the goals for therapy, meaning that our patients, only 50% were what we called virologically suppressed. Now we're at like 95, 98% of individuals who are taking medication are suppressed, and it's thanks to what we've been able to accomplish. We have an interdisciplinary team where it's myself, a physician, case manager, and a nurse, all helping the patient to succeed. That's our goal. So I really think that if you're interested in telehealth, it doesn't have to be this, I have to see the patient face to face in order to maximize what we're doing. The other thing is that right now, some of these buzzwords, aside from coronavirus, besides telemedicine, is within ACCP, and I'll be recording my talk this week on comprehensive medication management. So this is really a buzzword for ACCP, and basically it's what we've been doing for a really long time, but we're trying to put a process together as to how we manage a patient comprehensively. So it's not only just looking at their medication taking behaviors, it's also looking at their cultural beliefs. I have patients who tell me on Saturdays, I refuse to take my medications because of religious, it's my religious holiday every Saturday. So, I have to take that into consideration when I'm, talking or educating a patient of how to take their medications. So I think, operationalizing what we should be doing is a good thing. But now the next step is, how do we operationalize comprehensive medication management in telehealth? Really no different of what to do. But again, I think it's just, how can we prove our worth? And again, I always talk about, when I first started, I couldn't do research in my population because they were prisoners. It took me almost 4 years to be able to get my first IRB, or Institutional Review Board, application approved, because nobody wanted to let me do retrospective research on prisoners, because I was, evaluating prisoners in maybe a way that would be unethical. But again, I think, the persistence and the perseverance showed that we're actually doing a better job. We're providing better services for some of our patients that are incarcerated than maybe our patients are achieving on the outside in regular clinical practice. So I think you just have to keep persevering. And, telehealth that buzz may go away. Again, as Dr. Chan was saying, with reimbursement for services, I think that's another area that we're looking, how can we make sure that we're reimbursed? The nice thing with Dr. Chan and I is we're on a contract. So we don't have to go through all of the billing requirements, but the Department of Corrections pays our salary, so we don't necessarily have to recuperate those costs. So that makes our lives easier there. But with coronavirus going on, there were a lot of emergency orders that were allowed, and that allowed telehealth to be covered. I hope a lot of the insurance agencies don't go back and say you have to do face-to-face, because I think what we've been able to provide our patients with is additional access to care. We can see them outside of traditional hours of, that 9 to 5. And I actually, with telehealth, get to see every patient, whereas ordinarily there's usually 4 providers to my oneself being in the clinical environment, where I don't get to see every patient, where at least now I get to make a difference in each patient that I see. And I get to see all 700 patients that we carry on our IDOC load for the HIV side of things.
Wow, thank you. Okay, next question is, where have you felt you've been able to make the most impact during your career? And let us know if there are any patients that stand out for you that you know you made a difference for, or that you just are memorable to you.
I always joke that if I remember your name, you're either a troublemaker of a patient, or I've really made a difference in their lives. I guess I'll start with this. So where have you felt you've been able to make the most impact during your career? So let me, I look at it in various facets. And like Dr. Chan talks about, as a faculty member, you are responsible for service, scholarship, and teaching. So again, I think about it in those compartments. I'll start with research. For those of you who know me, when I was a resident, I hated research. It was because I had a terrible experience. I remember doing transplantation research, and I had 600 patients for my PGY 1 year to get through. And there were like 60 to 70 data points, and my preceptor did not help me at all. So I'm like, oh my gosh, research is miserable. I hate it. I can't stand it. But then I thought about it, and I was like, if I'm going to have this experience, there's got to be other people who have this experience. So maybe I should turn it the other way and make it a better experience for students. So when I came here, I started getting emails from students about doing research. I did not have the foresight to do all of that when I was a student, so I commend each and every one of you for doing so. And I thought that, you know what, I'm going to make it into a positive experience. And I've done that since coming here. I have students who have gotten to present internationally, poster presentations. I have students who've, seen the projects all the way through from the beginning, where they've submitted IRB, they've done a data collection, they've helped create a poster, and they've completed it out with a manuscript. It is no better feeling from myself, aside from you doing all of my work, which is amazing. But then also seeing that acceptance, just seeing that it was such a positive experience. That is probably one of the best experiences I've had, and I've got to work with a lot of students through that. So thank you for doing my work, but then also seeing those eyes light up in that sense. I think it's a really cool experience. So moving on to teaching, I've just been looking at evaluations for another thing that I'm working on, but I worked for a class that Dr. Popovich would do advising and mentoring before you all had to do flames. And so I shared my experiences. And when I'm having a bad day, which is far and few between, or it's been like a tough day, reminding myself why I got involved in teaching, I pull out those reflections that the students had written, and they are probably some of the most uplifting things that I've seen. A lot of my rotation students, I think about, and so it's not just this one, standout moment, but knowing that I've made a difference in a student's life, I honestly, it's been very, very rewarding. Whether it's on rotation, whether I've changed their perspective of something, and I've changed a lot of students' views of what they want to do when they grow up. You know, some people have said that, you know, I'm one of the P4 coordinators for Flames. And, you know, we get some love and hate mail on those evaluations. And yes, I read every single one of those. But it was one of the students who had said that if they're not pursuing a residency, they feel that they're not valued at UIC. And I went back and I wrote to that student, and I was, you know, I was like, I'm sorry you feel that way. But I will tell you that when you come on my rotation, and this person was not on my rotation, but I make sure that I know where the student is wanting to go, and I tailor that experience for them. So they don't feel that if it's just clinical, that that's all UIC churns out. That is not true. So I hope that nobody feels that way, because it's retail, it's industry, it's hospital. We're all pharmacists. We are all going to be colleagues. And I think that's the most important thing that we need to think about. So there's been a lot of those moments that have stood out for me. And as for patients, there's so many patients that have stood out to me in my career. Again, I get to really connect with our patients just because, you know, in the provider's office, or, you know, a lot of times when they're seeing the provider, there's a lot of metrics that they have to meet. And so they have to see so many patients per day, or there's 5 other patients waiting for them to be seen. I get to take my time and spend time with our patients, really get to know them and some of the hurdles that they're going through. I have a lot of patients who will come and only tell me the truth and won't necessarily tell the provider their truth. So there's just been so many that I feel that I've been able to impact. And yes, there's always going to be those people in all facets that you remember because of the not so great experiences, but those not so great experiences are very minor compared to the amazing experiences that I've had in all facets of teaching, scholarship, and patient care.
Okay, so for me, I have to again echo what Dr. Badowski is saying. I've been doing this for quite some years, and I never really envisioned myself teaching at all. If anyone knows me 20 years ago, I was probably the worst teacher here at UIC, never had an interest in teaching. I was being a true B. So that way you didn't have to take my rotation. I did everything to avoid you guys. But I think throughout my years, I realized that you, the student, is the future, and that if anything, I owe it to you and the profession to see where you guys can go and where you can end up. And I think over the last decade, you guys make me who I am. You make me learn. You make, it's like you keep me on top of things when we're on rotation. Those who work with me on research, we are, you know, close. We have good relationships. Those who are out and about, they still bother me. It's like a thorn on my side that I can't get rid of you guys. But that's the beauty of being in an academic institution, is having students on service, and those who you meet, you see them grow. It's no different than having your own child, and you guys are all my children, I guess, in a weird way, that I can see you flourish to be out in the real world and see where you end up. And there are many throughout the whole country. Once they graduate, it makes me proud to see where they end up, if they're directors of pharmacies, or if they're, you know, in these unique positions in IT, if they created their own position at University of Chicago, you know, and it's all because I had a little part in their lives while they were at the college, is where they end up today. So I think that that is probably the biggest impact. It's not about me, you know, cranking out research and seeing my name in print. That means nothing, but it's really the the relationships that I have created throughout the years with the students. And I think for many of you, please don't see your professors as a divide, as like, well, you're a professor, I got to respect you, you're up here, and I could never really talk to you about things. We're all human. Like I always say, we all sleep, we all eat, and we all poop. You're no different than me, and I'm no different than you. Even though I'm the GI queen, doesn't mean that my poop comes out as gold, okay? So we're all the same, and I think that just have the courage, go talk to your preceptors, because they are the ones who would be your lifeline for the future, and they will be here for you even after years to come when you graduate. In regards to patients, like Dr. Badowski says, you know, there's always that bell-shaped curve. There's a lot that's forgettable. Like you guys in school, you don't want to be part of that bell-shaped curve being in the middle, but you don't want to be on the side that you are going to be memorable because of things that you should not have done, but you want to be on the side that shines. And there's many, and too many to state, but there is one I believe Dr. B and I could remember that both had HIV and Hep C. And
I know exactly who you're talking about with that.
right? Yep. So all I can tell you is that during my time, the medications, interferon causes people to go a little crazy, zonky. They can have, you know, suicidal thoughts, homicidal thoughts, and this guy was all the above. But anyways, what made it more memorable is that we liver clinicians cut him off of his treatment because he did get a little nutty. And then to get attention, he actually threw feces at the guards to get them, to get us, to get him back on treatment. Surprisingly enough, psychiatry approved him to be back on therapy despite everyone else saying no. And he is, I believe, Hep C free. I thought he had left IDOC, but I think he came back.
He
again.
did. He was never coming back, and oh, we knew he'd be back.
Yeah.
He's back.
So, but the good thing about my position is that for hepatitis C, it's a very short duration of marriage. I can annul the marriage easily after about a year. I mean, from the time I start seeing them until they get treated and a cure for their infection. Unlike other disciplines, they are kind of stuck with you for quite some time, like Dr. Badowski, until life. So that's the good thing about my position, is that there are some patients I do miss when they are done with their treatments. In the old days, it could be like 18 months. Now it's as short as 3 months. But then those, like the patient we just mentioned, we can't count the days down quickly enough, like you guys counting the school year down as quick. So I think that is all I'm going to say about the patients, but at least we both know who we're talking about, right, Dr. B?
Absolutely.
All right. Any other questions out there? I guess there's 3 minutes left.
Yeah, I think we're at audience Q&A now. So if anyone has any questions for Dr. Badowski or Dr. Chan, now's the time.
Hi, Dr. Badowski and Dr. Chen. Thank you guys for sharing your experience. So I do have a question. So as the pandemic starts, so I think there's a lot of changes with, I'm not sure about telemedicine, but based on your experience, do you think there's anything that we can do better with the telemedicine, or is there any limitations that you have with the telemedicine? Can you share some with us?
I think we all should have been doing telehealth a long time ago. I mean, honestly, I think it's quicker. I think it's like, I call it like drive-through medicine. I can see somebody for follow-up in 15 minutes or a new patient in like 30 minutes. The wait times are a lot shorter. The access is, you know, amazing. So I think we should have all been doing this like for chronic disease states a long time ago. Obviously, like if you need something physically examined, that's a little bit more difficult, but I'm a total believer in it.
I think we're all doing telemedicine. Even back in the day when I did my Hep C clinic that I created back in 2002, patients would come by and get their medications. They come by once a month to get their labs drawn. But in between, because interferon caused so many side effects, that includes flu-like symptoms, depression, irritability, food, it's like everything under the sun. I would call the patients, at least once or twice a week just to make sure that they're okay. I just didn't know it was called telemedicine back then. I just thought it was a friendly phone call. So I think that, again, it's a buzzword. People think that, oh my God, I'm doing something special. But if you're calling a patient, you're doing telemedicine. If you're at Walgreens or working at CVS and you're calling a patient just to see how they're doing, you're doing telemedicine. It's nothing really special or something different that we need to do. More importantly, it's just a way of communicating with patients and making sure that they're doing well and taking their meds and they're not having any adverse effects from it. So I would just take that away and just think it was mom or dad on the other side of the country or other parts of the world and you want to make sure that they're doing well. What do? FaceTime them, Skype them, pick up a phone. Same different. Those patients on the other side, just your parents. No different how you would take care of them. Other questions from the audience?
So I'm sorry, I have another meeting that's starting at 5, so I'm going to have to bounce off. But thank you again for the invitation, and sorry to leave you, Dr. Chan.
That's okay. I'll finish this off.
Thank you.
Bye. Make sure you sleep
Thank you
tonight.
so much, Dr. Badowski.
Thank you again.
Any other questions from the peanut gallery? I'm here. Did
you find someone you want to pick on, Dr. Chan?
You? Can I pick on you?
Sure, you can.
So what do you guys think you want to do? I mean, how many of you are P3s? Because I can't see. There's 33 of you guys. Some of you guys already left. But what do you think? What do you guys want to do? Is it telemedicine that you guys want to do? Do you want us in a room or do you think it'd be different? I mean, I think if there's anything that you guys can do right now is survey people around you, right? I mean, it's simple research. It's no different. You can just say, my God, we're in a pandemic. How are you seeing your patients or, your classmates or even your parents or your friends? Because I'm sure that they can't or they just don't want to go see the doctor right now. So if that's the case, you can already have a little survey going on within your own orgs. I mean, I think we're trying to do something with Maha Clinic right now that we can talk about and just calling patients up and just seeing what their opinions are. Is it any different? I mean, prisoners don't have an option, right? They're lucky to even have us taking care of them. But for patients, they have a choice to come in or not. And I think that there is, at least for APA, a social barrier possibly because they don't want to go to a hospital where they can't understand the doctors. So is this going to be better or worse for them if they know that they can talk to someone on the other side on the phone or on the TV screen who is able to communicate with them? So they might have better access to care than what they haven't had over the past, years. So, I mean, I think it's a very interesting times and using our backgrounds to see if we can help patients who are vulnerable, for sure. And I think that's something that, the org can definitely take a look at, especially since we are kind of limited in terms of the hands-on activities or, the health fairs that you guys are all interested in doing, the diabetic health fairs or the high blood pressure clinics. You can't do that right now. So what are you guys doing in exchange for it? How are your members trying to get something out of it? And I think, at least with APA, we're trying to be creative to have these opportunities that you can still do from afar. So like I say, think outside the box. Anything is possible. If it doesn't work, try something else, right? That's all you can really do right now. So other questions from you guys? Yvonne's like looking at me. Smiling as usual. What's in your head?
My head.
Yeah.
Oh,
Your brain has to be bigger than mine. I know that for sure.
because I didn't have too much experience with telemedicine, but I know that it will definitely be something that is popular in the future because there are also a lot of remote pharmacy that kind of like start establishing. So yeah, I think right now maybe just be like familiar with how it works might be helpful in the future, I guess.
Mhm.
But I also kind of like afraid about maybe like the in-person connection between patients because right now we have school that is all online and then we kind of like miss what we had before. So I just wondering if there's like any difference between like all remote and then patient interaction, etc. So
Think about it, and it's what's interesting what you said, Yvonne, is that you don't have the experience in telemedicine. But to be honest with you, all the 24 people still on this call, well, mine's myself, so it's 23. You guys actually have more experience than us clinicians right now. If you think about it, you go to class every day, and I'm going to assume that they take attendance or whatnot. So at least in the past, you don't have to show up to class, but now you might have to. But if you're actually online and you're cooking or something or whatnot, you're doing telemedicine. It's just, you're just communicating in a different way. Now, the question is, do you feel like the interaction I'm having with you right now, would it be any different if I was in class talking to you? The difference for me, if I was in class, and for those who know how I teach, I would just be pacing back and forth, walking a classroom. I just can't sit still and not move. But right now, the difference is I'm sitting here and I'm talking to you and looking at a camera, but my delivery, my message, is that any different than if I'm in a classroom? So think about it that way. And if it's not, then you know you're providing a service that you can. Now, you doing this so-called Skyping, or let's call it telemedicine, I can still ask you, hey, Daniel, how are you feeling today?
I don't know.
You're okay? You sure? Mentally, you're all there? Are you having any problems? Do you have any coughs or chills?
I'm good right now.
Yeah, you're good. Did you go test your temperature before going to school today? Did you have lab?
I did not take my temperature before school because I didn't go to school, but typically last time I checked was Sunday for work and I was okay.
You're okay. All right. So, but you don't know if you've been infected since then, right? Because you did go to work.
Correct.
Yeah. So technically you could be there infecting other people like President Trump. So what did I just do with Daniel? I just had telemedicine clinic with him. He told me about his temperature. He was normal. He says he's out and about. He feels symptom free. He's still working. So what I just did with him is I just had a clinic. And if I could bill for that service, I would. Now you owe me $10, Daniel. Okay. So it's not, I think that's what people say. Again, it's a buzzword and it's what you're already doing. Now you should be able to take your experience, Yvonne, day one of class, College of Pharmacy. What happened to everyone? Could you log on? Was there technical difficulties?
no.
Everyone was having problems, right? Thank God I wasn't teaching this semester, but everyone else that was, there was a lot of stuff going on, email from a faculty side. So that's what you got to think about. Your talk was like, I don't have the experience. What would I do differently? Well, you had a better experience than I because you were actually sitting in an environment in your room where you couldn't connect at all. So you to think quick. I need to get to the class. How do I get there? I can't drive to school. No one's at school anyways to teach me. How do I get reconnected? Who do I contact? Those are the more important skills that you're going to be taking away with you for the future. And it wouldn't be any different is what if you're waiting for a patient on the other side and you're expecting them to pick up the call and they're not there? And then what do you do? Well, okay, if I can't see them on a TV screen, maybe I'll call them on their cell. Well, maybe their cell, they don't have it because they didn't have any money to pay for their cell phone. So then you have to think about a following month, what happens, right? So there could be a lot of things. Maybe you need to help them get a cell phone payment or you know, things that you would never imagine, because a lot of patients, they live paycheck to paycheck. All right. So if that's the case and their cell phone versus food on the table, what are they going to sacrifice? Their cell phone. They're going to get food on the table. So you might be able, as a healthcare provider, help the patients get money to pay for their cell phone. And it's not uncommon. We've done that when we were in clinic frequently. A lot of times we help them, you know, connect them with a social worker. The social worker is able to get them insurance or, you know, cell phone money. So that's the experience. Stop hanging on this telemedicine. It's kind of cool that you put this whole thing together, but we're all pharmacists at the end of the day. And then you decide what organ you want to play with. And then that's what you become specialized in. If that organ is no longer in business, go find another organ to play with. That's all that matters. Drug information and having your opportunities be forward coming to you, and don't, I guess the other thing is networking, and don't break any bridges, okay? Because it's a very small world out there. If any one of you heard, I went to Hong Kong one year with my parents. I was there to give a talk to University of Hong Kong. I was there to teach inflammatory bowel disease and liver diseases. And then I went to a restaurant with my parents after teaching that night. I went to the bathroom, and who did I see when I turned around? A student who was here at UIC. Actually, she was a pharmacist at UIC, just to see what we do, because we have all those international programs with Dr. Lau. And she was here for like a couple of weeks shadowing us. And I'm like, oh my God, I know you. And this was like in a bathroom stall once we came out. It's like, this is unreal. So pharmacy is a small world. You just don't know who you're going to run into. So make sure you don't burn any bridges from now to then. All right. Any other questions? You know where to find me, and you know where to find Dr. Badowski. If you have any other questions or issues about telemedicine or just life in general, we're here to help address them for you.
Thank you, Dr.
All right, cool.
All right. Thank you so
No
much,
problem.
Dr. Chan.
Hope you feel better, Daniel. I am going to bill you for, I'll give you a discount, $8. I want my $8. Okay.
As soon as we get that lobbying in place, I'll pay you.
We'll make it soon. Okay.
Okay.
Thank you everyone for joining us today. So if you need like Flames credit, make sure you click the attendance link in the chat. Thank you.
Bye.
Bye.
Thank you guys. Bye bye. Have a good rest of the day. Bye.